of the bottom of the tree or the roots, we're talking about understanding what juvenile arthritis is and what it is not. In terms of the trunk of the tree, we're going to talk about understanding the core features of juvenile arthritis. And that includes talking a little bit about the categories and the subtypes of juvenile arthritis that some of you may be familiar with already. In terms of the branches of the tree, we're going to be talking about understanding the treatment arms, and Dr. Guzman will go through that with you in some detail, as well as the top of the tree, which is really understanding outcomes. So this is often what families want to know. What do we know about the outcomes for children with juvenile arthritis? So first of all, talking about the basics, what juvenile arthritis is. Actually, part of the name is explanatory for what the condition is. But if you break it down into its subtypes, the J stands for juvenile, which by definition is before the 16th birthday. I is a word that's idiopathic, which in medical terminology just means that we really don't know the cause directly. So we don't have a direct cause that we can think of as why a child might get arthritis. So it's not from an infection, it's not from a gene that we know about. And A, of course, is for arthritis. That by definition is joint swelling, stiffness, or difficulty walking for more than 6 weeks. What we also know about what JIA is that it is different in each child. So we treat each child very differently and as an individual. And there are at least 7 diseases or categories that I'll go into in some detail. We also know, thankfully, that juvenile arthritis is much improved with current treatments and that we're constantly looking for new treatments and new research as time goes on. What JIA is not, I think, is really important in that sometimes you'll hear family members or you might have friends that when you explain to them that my child has arthritis, these terms might come up, and it's important to know that this is not what juvenile arthritis is. So it's not the wear and tear arthritis of older age, that's called osteoarthritis. It's also not the destructive arthritis of middle age that you might be more familiar with, although there are some subtypes in juvenile arthritis, as I'll explain, that are more similar to these subtypes in adults. It's also not gout. So we often get a question about whether this is related to gout, and gout is a very different disease that is more seen in an adult population. JIA is also not a genetic disease, and probably some of you might prick up your ears and think, but you've had some genetic testing over time, and certainly there are markers that we look for that are genetic markers for specific subtypes of juvenile arthritis. But what we know is that there's no particular gene that we can look for as a cause. It's also not contagious, so it's not transferable from child to child, from family member to family member. It's also not something that the child did. So it's not something that the child ate or anything that happened to the child. Often though, from history, we know that sometimes a child might have had a minor injury that brought attention to a joint that might have been swollen or stiff or sore, but it's not something that the child did that brought on the arthritis. So we've kind of gone through the first learning objective, and we're now going to focus on the core features of juvenile arthritis. You'll have plenty of time at the end to ask any questions if this is unclear. I guess we had an idea that maybe in a clinic setting it can become quite overwhelming by some of the terminology that you hear and some of the words that are used in a clinic setting, and you're not quite sure how they fit into your child. So when we talk about normal speak, or I guess words that a child might use or a family member might use to describe symptoms, the most sort of common symptoms that we talk about are pain and stiffness, maybe difficulty walking and swelling. And of course, when we're talking about those symptoms, the part of the disease that we're talking about is the arthritis. Other children may complain of things like heel or back pain, and in those cases it's a particular subtype that we're usually talking about, which can be related to enthesitis or sacroiliitis, so inflammation of the back. As a lot of you will know, we do regular eye screening for our children, and some of the symptoms that are related to the eye might be pain, redness, or difficulty with vision, so blurred vision, and this is in relation to uveitis. And the fourth group of symptoms that we commonly ask about in clinic would be rash and fever. And when we're talking about rash and fever, we might be talking about systemic features in relation to systemic arthritis, but we also might be talking about psoriasis in relation to that particular subtype. I just thought I'd show you one of these diagrams of the pathology of the joint. And you may have seen this before, but essentially if you focus on this top left diagram, this shows you the cross-section of a normal healthy joint. You can see that a bone is meeting a bone, and in between you've got the articulation of the joint. Just try and get my pointer. So here you can see the articulation of the joint, and this is what we're talking about when we're thinking about the structures of the joint. So you can see that in a normal healthy joint you've got a thin synovial lining, so this is the synovial membrane that's lining the joint. You can see that the fluid, this blue area, is not too full and thick, and you can see that the bones are touching each other nicely with a thin cartilaginous layer. If you look at the bottom picture on the left lower picture, you can see that the synovial membrane has become thickened, and that the fluid itself within the joint is also thickened. And this is what we're talking about at the joint level when a child has arthritis. On the right-hand side, what I wanted to show you was what enthesitis looks like from a pathological point of view. So what we're looking at here is an ankle, and actually this ankle should be straight up. There should be no bulge there, and what you can see there is the tendon because it's inflamed and bulging. You can see it in cross-section in the picture form on the right-hand side, and basically that shows that the tendon is meeting the bone, and at that point there's inflammation, and that point of inflammation can cause pain, and that's often the tenderness that children will be describing, maybe in their heels or in the bottom of their feet. In terms of investigations for juvenile arthritis, it's often one of the big questions that we get asked, what investigations will help make this diagnosis? And I guess an important point to make is that investigations or tests don't make the diagnosis of juvenile arthritis. It's a clinical diagnosis. We do use blood tests, as many of you will know, for very specific reasons. So the first group of blood tests that we use are to help us with subtyping or with categories. So we look for an ANA to see the risk of uveitis. We look at other markers such as HLA-B27 and rheumatoid factor to look again at categories of juvenile arthritis. The second set of blood tests we use are to look at markers of inflammation. So we're wanting to see the child's progress over time in terms of how much inflammation they have in their body. And finally, we're looking at screening blood tests. So we want to know the effects of the medications that we're using and how they are impacting on the structures in the body, such as the full blood count and the liver. In terms of images that we use, again, the images don't make the diagnosis, but they can be very helpful. We may use x-rays as a baseline or to track progress over time. Ultrasound can be very helpful, particularly when we're using intra-articular steroids to help us to localise the pathology in the joint. And MRI can be very useful in complex joints when we want to know more about the joint pathology. So we'll just move on to the 7 juvenile arthritis categories, and I think this slide is important in that it shows that you can see a very wide spectrum of children that can be affected by arthritis, and that these different subtypes affect children differently. Oligoarthritis is the most common subtype of juvenile arthritis that we see. It's often in young girls, and these children have a higher risk of uveitis. By definition, the children have less than 4 joints affected in the first 6 months of disease, and a subset of these children may go on to have more than 4 joints, which we call an extended subtype. Many of these children will present with maybe a knee, or there may be some other joints involved, but there are certain joints that we know about, such as the wrist, that have higher risk of extension. The subtype polyarthritis rheumatoid factor negative is the second most common type of juvenile arthritis. These children have more than 4 joints, so 5 or more joints in the first 6 months of disease. The rheumatoid factor is negative, which is an important distinguishing factor from the other group, and they're often older girls. Again, we need to screen these children for uveitis because, like the oligoarthritis children, if they're ANA positive, they can have a risk of uveitis. Enthesitis-related arthritis is quite a different group. This group includes children who have arthritis, as well as the enthesitis that we talked about on that slide, the inflammation of where the tendon meets the bone. These children are often older boys, and they have other features. For example, we may have looked for that genetic marker that I mentioned, HLA-B27. They may have involvement of the back or the spine. And these children have quite a different presentation of uveitis. If they have inflammation of the eye, it tends to be more acute, so more sudden onset, and they tend to get more redness of the eye and more pain. Psoriatic arthritis, again, is another subtype where the children have involvement of arthritis, but also have psoriasis. Interestingly, though, there are other children that we may classify as having psoriatic arthritis based on a family history. So if a first-degree family member has psoriasis, we still may classify that as psoriatic arthritis, as well as some other distinctive features, including dactylitis, which you can see in that top left-hand picture. So you can see that the toe is quite swollen. So that's quite a specific feature of psoriatic arthritis. And of course, they can also have the psoriatic rash themselves. Systemic arthritis, again, is a very distinct subset. And these children not only present with arthritis, but also have fever and rash as a predominant set of symptoms. The rash is very typical. It's a pink rash that comes and goes. And they can also have involvement of lymph nodes, so you have large lymph nodes and enlarged liver and spleen. In adults, this condition is described as Still's disease, which is a similar condition to the childhood onset condition. And this condition can affect children of all ages, but generally we see it in the ages of 3 to 12 in both sexes. Polyarthritis, rheumatoid factor positive disease. The arthritis affects 5 or more joints during the first 6 months of disease, and these children obviously have the marker rheumatoid factor positivity. This is a very rare subtype of juvenile arthritis in less than 5% of our patients, and this is the subtype I was mentioning that's more similar to the adult form of rheumatoid arthritis. Generally, we see this form of arthritis in our teenage girl population, so between 9 and 15 years. And then we have a category that you may have seen in your clinic letters or your notes that's called undifferentiated arthritis. And essentially that means that the child fills criteria for more than one category, or that perhaps they have an exclusion criteria. They have a marker that we've found that means that they don't fit clearly into one category. So I guess the importance of knowing those subtypes is to think, why do we need to know? So that comes back to the summary of these clinical features, in that juvenile arthritis is a clinical diagnosis, as we've said, and that blood tests don't make the diagnosis, but can be helpful, as can imaging. The pattern of clinical features is really important because it defines the subtype or the category. And what we know is that the category influences the treatment choices, the way that we screen the children and the way that we follow them up in clinic. And it also has some implications for outcomes, which Dr. Guzman will go into further detail. Just as an aside, that the category of arthritis may change over time, and you may have already had that experience that the category of arthritis can change. That can be quite confusing, but essentially it means that we're thinking of this constellation of clinical features all the time and trying to fit together the best management plan for the child. So with that, I'm going to hand over to Dr. Guzman to talk to you about understanding the treatment arms.
Thank you, Georgie. Please, if you have questions, do make a note of them, because after I finish, Georgie and I will be in the front and we will be answering all your questions around anything that we say during the whole presentation. So let's focus now a little bit on the issue of the treatments and how do we understand the different treatments that are used for juvenile arthritis. So the very close to the trunk of the tree is what is basic non-pharmacological management that is applicable across all JIA categories, which is the basics of the learning that you do as a family about what the arthritis means and what to expect, the support that you provide to your children, plus the support of physiotherapists, occupational therapists, the nursing, social work, in helping you through all the learning that happens during the first several months of the disease. Then you have specific interventions from the point of view of what the physiotherapists or the occupational therapists may recommend to help manage things, maintain function, and help prevent deformities. And the last but not least is the basics of having a healthy nutrition and a healthy level of exercise. Many years back, rest tended to be the recommendation for arthritis. Now we understand very clearly that that is not the way to go. You need to encourage activity as much as possible so that you keep that range, you keep that mobility for the long haul. So that said, that is the trunk of treatment. But then you have a whole lot of different options for medications treatment, for pharmacological treatment, and there are literally dozens of medications for arthritis. I am old to know that this was not always the case. When I started in my training in pediatric rheumatology, we had basically 2 or 3 things to offer, and the results were not pretty. Nowadays, we have dozens of different medications that can be used, and part of the challenge is how do you make sense of dozens of different medicines altogether? So the way in my mind I make sense of this is by summarizing all of those multiple medications into just 4 main groups. The other thing that often comes by is why are you using medications that decrease the immune system? Isn't the immune system good? Well, yes, it is, but although we don't know the specific cause of arthritis, we do know that one of the main things that happens is that the immune and inflammation system in the body are not working properly and are attacking the joints. So many of the medications that we use is to try and dampen down that inflammation response or that immune response so that you don't have the attack to the joints and other parts of the body. So this is the first group of the 4 groups that I talk about on medications. And this is kind of the basic group that has been around for a long time, which is the anti-inflammatory medications. These are medications that decrease the amount of inflammation that you have in your body, no matter where the inflammation is. So you may know aspirin, naproxen, ibuprofen, Advil, all of those are different names, different medications that fall within the group of anti-inflammatories. They tend to have mild to moderate potency, and their main way they work is by blocking substances called prostaglandins, which are substances that mediate and produce and accelerate inflammation. Now, one thing that I always try to tell parents is anti-inflammatories have 2 kinds of actions. Everybody has given Advil to their child, or pretty much has, for a fever or for pain. When you use it occasionally, 1 dose off, typically it starts to work in about half an hour, and you will have some decrease on the fever, you will have some decrease in the pain. But if you want to have real effect on the inflammation in the joints, giving it that way is not enough. You need to give it regularly, by schedule, and at least for 4 to 8 weeks to see the full effect in decreasing the inflammation in the joints. This also becomes an issue sometimes when you talk to families, to your relatives, or even sometimes with pharmacists, because they are so used to using just for pain and fever that when you see the higher doses that we use and the regular medication, sometimes say, why are you doing this? Well, the reality is this is what is needed, and this is what it has been tested and established to work. So if you want to really give it a trial, you have to give it a trial long enough at a good enough dose. Now, they don't work for everybody, but they do work in the majority of people, at least partially, at least decreasing some of that pain, decreasing some of that inflammation. Side effects. Obviously, as a parent, you always worry about side effects. That's part of your job, to worry about that possibility. Now, one thing to remember is that anti-inflammatories can have different side effects depending on the age of the person. Now we know that if you are in your 70s or 80s, you have heart condition, anti-inflammatories are a bad idea, really bad idea. But for children with arthritis, It has been used for many, many years, and it actually can be very beneficial with little chance of side effects. What kind of side effects you can see? Most typically some abdominal upset, and on occasion you can see more serious gastrointestinal problems because of the medication. Issues with kidney are very, very uncommon in children, but they can be seen in adults. In any case, obviously we are using these medications and monitoring your children. And the reason why we use them is because in the balance, the chance of side effects is small and the chance of a benefit is quite substantial. So those are anti-inflammatory medications. The second group I want to talk about is a group of medications called corticosteroids. Now, these are much more powerful than the anti-inflammatories that we talk about. These are all relatives of actually a human hormone, the cortisol. Cortisol is a normal constituent of the bodies of everybody. If you don't have cortisol, you just die. It's an essential to life hormone that we all have. But when you receive that hormone or medication similar to that hormone at a higher dose than what your body produces, it dampens down the inflammation very quickly, very reliably, almost in everybody. There's a few people that may not respond, but most kids will have a very significant response to this. I don't mean to scare you, but one of the important things to remember about corticosteroids is in some rheumatic diseases, before we had corticosteroids, children actually died from the disease. It was the discovery of corticosteroids that allow us to control in those dreadful situations the inflammation to a degree that allows survival. We're talking about 50, 60 years ago. Now, corticosteroids can be given in different ways. They can be given directly into a joint through an injection, and that can be done with some sedation or sometimes with anesthesia if necessary, depending on the age of the child. They can be given by IV, particularly when there is a life-threatening condition. For example, in systemic JIA, when you have a lot of fevers and a lot of rashes and all of that happening. Or they can be given as a pill by mouth. The reason why we use it differently is because we're trying to always balance the chances of a good benefit versus the chances of a side effect. When you use the corticosteroids in the joint, the chances that you will have side effects in the rest of the body is very small. And the chances that they will work and decrease inflammation in that joint are very good. Now, when you have inflammation all over the body, like in systemic JIA, it will help little to have it in the joints. So then you use it in another way. You use it sometimes IV to try and control inflammation quickly. And the tablets, the prednisone tablets, usually can be used in two kind of different ways. First way is what we call bridge therapy, meaning to buy time while other medications take effect. Or sometimes we use it as a main treatment, particularly or usually in kids with systemic arthritis. One last thing to remember about corticosteroids is it is important to taper. This is a medication that cannot be stopped suddenly. So what are the corticosteroid side effects? Well, they clearly depend on the dose and how you use it. As I said, if you use a dose in the joint, the side effects in the rest of the body will be minimal, if any. If you use it at very high doses because the severity of the disease requires it, then you can have a significant amount of side effects. Now, they come in basically three different kinds of groups of side effects. First one is from dampening the inflammation. As I said, these are some of the most powerful medications to decrease inflammation that we know of. But inflammation in some contexts can be helpful. like when you have an infection. And so that dampening of inflammation does increase the chance or difficulty with responding to infections, depending on the dose of the medicine that you are taking. Now, the second group of effects come from other hormonal effects. In the body, cortisone has many effects. And so if you are on a cortisone-like medicine at a high dose for a long time, then you can see some of these effects, increasing the blood pressure or increasing your sugar in your blood, your glucose. In kids, we are primarily concerned about delayed growth. If you use corticosteroids for a long time at a high dose, you don't grow as fast. You slow your growth from during that time. The last issue with side effects is that when you are receiving these medications, your body stops producing their own cortisol. And so if you stop the medication suddenly, your body doesn't have enough time to catch up. That's why these medications should not be stopped suddenly. They have to be tapered down. Of course, it depends on how long you have been in it. If you have been for years, you will have to taper down over a long time to allow your body to take over and produce their own cortisol. Now, this is just a little bit of a, you're going to see many of these slides, just to give you a little bit of a sense of the different way that the different disease, the categories of the disease get treated. What you can see here is the categories of the disease that Georgie talked about, that Dr. Tyler talked about: oligoarthritis, polyarthritis, rheumatoid factor negative, and so on and so forth. And here what you see is the chance in percent that somebody, a child with that kind of disease, will receive joint injections within 2 years of diagnosis. As you can see, more than 50% of children with oligoarthritis will receive joint injections. They are a well-established treatment that works pretty good. And when you only have a few injections, it's not that hard to do. Contrary to that, you can see that for kids with systemic JIA, we rarely, not as frequently, use joint injections. We often use corticosteroids more by mouth or by IV in kids that have that disease. Now, this is the opposite on that. This is the systemic corticosteroids. And as you can see, kids with oligoarthritis rarely, if ever, need any corticosteroids systemically. Systemic means by mouth or by IV. And typically that is almost never used in children with oligoarthritis. There's the occasional one that becomes extended and eventually requires some of it. But the bulk of the kids that receive corticosteroids nowadays are kids with systemic or with polyarthritis rheumatoid factor positive categories of the disease. So we have talked about anti-inflammatories, corticosteroids. Now the third group is something that is called DMARD. You know, I don't know who invented these different letter names, but that's what we have used for many years. That stands for disease-modifying anti-rheumatic drugs. And these are medications that are, one, can be very effective in controlling the inflammation. Two, they are slow. They typically take a while to hold on and to start working, usually anywhere between 3 to 6 months. Remember that we talk about the option of using corticosteroids as bridge therapy? Well, this is why they are used as bridge therapy, because these other medicines take a long time to actually get working. But when they work, they can work very well to the point that all of the disease gets controlled. There are many of those. The one that is most commonly used is the first one in the list, the methotrexate, but you can see a number of them here. And this one at the bottom is something that is a new medication and is not yet approved for use in children, but there are studies ongoing about its use. It seems to be quite powerful in adults, in adult trials, and we have great hopes that it will work quite well for children as well. So as I was saying, methotrexate is the most common of the MARTs, and it is not a new medication. But when it was first started, first discovered, it was not to treat arthritis, it was to treat cancers. As you can imagine, the amount of doses that are used to treat cancers are this high. The doses that we use for arthritis are this high. And the side effects are connected to the dose. Of course, if you use it at a high dose, you can have more side effects than if you use it at a slow dose. When used at a slow dose, small doses for arthritis, that has been one of the mainstays of medications for arthritis over the last 20, 25 years. Is usually at a maximum of 25 milligrams once a week. What are the possible side effects of methotrexate? It can have, again, some gastrointestinal side effects, some nausea, feeling a little bit not good appetite, poor appetite, those kinds of things, for particularly the day after you take the medication. It does require monitoring of blood work, so every 1 to 3 months, depending on whether things are stable or not. And we look particularly at two things in the blood work: the liver function test and the cell count. And the reason why we do that is because, of course, we want to be cautious. We know from its use in cancer and its use in other conditions that if you don't keep an eye on this blood work, and you let it go, it can produce damage in those organs. Now, we also know that if you monitor closely and you decrease the dose or stop if you see any of this, the kid is not left with any residual problem. That's why it's very important to do the monitoring. Now, this is a similar slide to the one I presented before about what children with what kind of JIA get the marks. And as you can see, virtually everybody with polyarthritis rheumatoid factor positive gets these medications. A good number of kids with rheumatoid factor negative polyarthritis also, and less so in the other categories. The last and fourth group is biologic medications. These are the new kids on the block, new, last 15 years. And basically what it means is that we learned through research of a way of producing proteins that are similar or block proteins specifically in the body, block functions, block mediators of inflammation. And these proteins are made in the lab to the use of DNA recombination. It sounds a little bit science fiction, but that is the reality. That's how they are done. And these medications are typically used by injection, either by injection under the skin like insulin, or by injection intravenously. Now, medication side effects for biologics, they can be some reactions to the injection in the part of the body where the injection is put. It can have some allergy reactions, and they do decrease in immunity inflammation more than the other medications, so there may be an increased risk of infections. There has been a lot of discussion and a lot of research going into the potential increased risk of cancers. One of the functions of immunity is to fight cancer. The immune system, one of its functions is to fight cancer. If you dampen down the immune system, the concern is, will that increase the chances of cancer down the road? And there are now very large studies in adults and in children that suggest that if they do is very, very minor, that in fact, the disease itself may increase the risk of cancers. And that adding the biologic adds very little, if any, to that risk. That's the last that we know. Of course, these medications have been around for 15, 20 years, so we haven't followed kids until they are in their 40s or 50s. So those longer term outcomes. We don't know. That's the bare reality. Biologic medications are used sparingly, typically when other things have not worked. And typically, the kids that will go and get those will be the kids with systemic JIA or polyarthritis rheumatoid factor positive. Although, on occasion, we use them almost in all categories. If the disease behaves in a way that does not respond to anything else, we may end up doing that. Just to summarize then, so basically there are many different medications, but I find it helpful to talk about them in 4 groups. And the issue is always to weight the risks against the benefits for that individual child. David, just a time check. What time do you want us to finish?
Got till 11:05, so there will be minutes left.
You lie. You said we had 60 minutes. Okay, so let's talk a little bit about understanding the outcomes of the disease. So there is a couple of things that are important to understand, because you probably will hear this in clinic as you follow with your child. Clinically inactive disease, what it means, we cannot find any sign of arthritis anymore. There is no swollen joints, there is no fever, there is no rash, the labs are normal, and there is no stiffness, or very little. Remission. Remission means we get there, meaning no signs of the disease, for at least 6 months. That is remission on medications. When we get there, we typically then wait a little bit longer and then stop or try to stop the medication. And we manage to do that in a good number of kids, meaning we get to what we call remission of medications, which means at least 12 months with no sign of the disease and no treatment. These are the chances of remission within the first 5 years after the diagnosis of the disease for the different categories of the disease. As you can see, the chances are pretty decent with oligoarthritis and not so good at all with rheumatoid factor positive polyarthritis. So depending on the category, the chances of getting to remission are different. The chances of flare are also different. Let's say that we got to remission, got off medications. There is always a bit of a risk that down the road there may be a flare. And flare is very hard. It's very hard for the families, it's very hard for the child. And these are the chances of a flare after stopping treatment. In summary, the outcomes with modern treatments are actually pretty good for many kids with arthritis. There is a roughly an 80% chance that there will be clinically inactive disease, no sign of the disease within 2 years of diagnosis. About 3 years of treatment is the average before we try to stop it if things are going well. And the chance of remission overall in the whole group of children with JIA is about 50% over 5 years. In summary, we talk a little bit, Dr. Tyler and I talk about the basics, starting from what is JIA, what is not JIA. Then we move to define the 7 different categories of the disease and how they are different. We talk about understanding the treatment arms from non-pharmacological to pharmacological treatment and the 4 main groups of medications. And then we spend a little bit of time understanding the different outcomes. They are different according to the category. Overall, they are much better than what they used to be. Not perfect, but they are much better than what they used to be. In fact, I like to show this photo to wrap up. These are kids with arthritis in the 90s, in your left. As you can see, an image sometimes speaks more than 1,000 words. You can see the wheelchairs, you can see the difficulties. And this is, I believe, last year's Calcium Friends run. It's this year in June, where you can see a whole lot of not only kids with arthritis, but all the supporting siblings and parents in the event that was held earlier this year. That is basically it. And I hope we have a chance at least for a few questions, David.
I have a question about how sick a child has to be to not have their injection. Because my daughter, she just started Enbrel and she's on methotrexate, and she'll go out of her way to say that her throat is sore, or because she has really terrible reaction to the medication, the methotrexate, she misses a day of school every week. So I'm just wondering, like, does she have to have a fever or a cough, or like what constitutes, okay, yeah, you don't have to take it this week?
Thanks for asking that question. I think that's a really great question. It's something that comes up a lot, and you can talk about what the medications are, but the practicalities for families are often much more difficult in reality. Injectable medications are challenging. Straight off the bat, they're challenging, and then specifically if your child is getting reactions to them, there are going to be multiple stepping stones along the way to get these. The question about illness related to injections on the day of injection is a good one, and what we usually say is that we're happy to answer that question at any time. So if you're worried about the level of sickness of your child on a day that they're due for either a methotrexate injection or a biologic injection, we're happy for you to contact us in the department and talk it through. Often it takes just a little bit of, problem solving to work out where the child is at, where the illness is at. And it may be as simple as touching base with your family doctor, checking out the throat, seeing is it actually an infection or not. But certainly, if a child does have a fever and is unwell, we would usually defer that injection.
And that's what I've done in the past, is if she's got a fever, I don't do it. But sometimes she has a cold, or sometimes she has a cough. She rarely has ever gotten sick until she was diagnosed, actually. But so that was kind of a thing of like, well, I'm getting a sore throat, and now being on the Enbrel as well lowers her immune system, so she's very scared about, I don't want to get sick.
Yeah. And children are clever, right? So they know themselves that there are risks with these medications as well. So I guess sort of to summarise that point is that we're always happy to talk it through with you and to troubleshoot at the time whether we should be giving the medication or not. And also your family doctor is a great port of call in terms of actually being able to eyeball your child.
Okay, yeah. So it's basically on a case-by-case basis.
Exactly.
Okay, yeah. Thank you.
If injectable methotrexate isn't effective anymore, specifically talking about uveitis with my daughter, is it normal to switch within the class of DMARD to a different one, or are you going into a biologic if the methotrexate isn't effective?
That's a very good question, and it depends on the particulars. So the answer will be different for uveitis, like in your child, or if it is because of the joint inflammation in a different child. For uveitis, currently, usually if we go all the way to methotrexate subcutaneous and it's not working, we believe the chances of getting control by change to another DMARD are quite small. We usually recommend going to a biologic. That doesn't necessarily apply to other childs where the problem is not uveitis, it's something else.
After a patient's in remission and they do have a flare-up, does this treatment start again? Would you start back at the beginning and start treatment again?
Another great question. Again, it's very dependent on your child, so it depends on the stage of, so essentially it depends on their category. degree and at the stage of disease that they're at, and we would fully reevaluate them at that time and decide on the next treatment course. Often it can mean going back to start with a new medication, so say if they had stopped non-steroidals or they had stopped a disease-modifying agent, we might go back to restart one of those, but it may not necessarily be the same medication. It might be from a different class, it might be from within the same class but a slightly different mechanism of action. But again, we would be encouraging you that if you're worried about a flare of medication or even a flare at any time, we're happy to discuss those problems and troubleshoot them with you in terms of getting the children into clinic to be seen and to reevaluate that situation.
Just to kind of wrap it up, because I believe this issue of flares is important. And we did a study not long ago looking at what does flare look like and what happens. And basically, most flares that we see in children who are being monitored in clinic are just a few joints, just one or two joints that become swollen. That's usually what happens. And usually, within the next 6 months, we manage to control things back. Now, it may not be exactly the same medicine that the kid was on before, but over about 6 months, we manage in most kids to control it back. And it's usually just a few joints that are swollen. I think we're going to wrap it up there, and thank you very much.